Okay, I do want to respect everybody's time, and I know Dr. Eglash has a lot of great information to get through, so we're going to go ahead and get started. Good afternoon, and thank you for joining us today for Contraception Options and Special Considerations During Lactation, hosted by HCET with presenter Dr. Ann Eglash. My name is Jordan Murch. I'm a training manager at HCET, and I will be moderating the webinar today. Let me briefly introduce you to healthcare education and training. HCET's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. HCET is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. Next slide, please. For more information and to keep up to date with HCET events, please be sure to follow HCET on these social media platforms and visit our website. Next slide. Now I will quickly review some housekeeping information. A link to an event evaluation will be sent to you via email following this webinar. Your feedback is always greatly appreciated. You can view archived presentations and a list of upcoming events on our website as well. If you have any technical difficulties during this presentation, please contact me, Jordan Murch, at the email listed on your screen. Next slide. In order to receive nursing contact hours for this webinar, participants must attend the entire webinar, complete the event evaluation, and submit the nursing contact hour form to HCET. The evaluation and nursing contact hour form will be sent via email following the webinar. Next slide. The presenter of this webinar does not disclose any actual, potential, or perceived conflicts of interest. Next slide. Throughout the presentation, we encourage you to send your questions via the chat box. To submit a question, hover over the main screen, then select the blue chat icon. Once selected, the chat box should appear on the right side of your screen. To send a question at any time during the presentation, please send it to all panelists. This ensures that everyone behind the scenes can view your question. We will hold all questions until the Q&A portion at the end of this presentation. Next slide. Now I'd like to introduce you to your presenter for today. Dr. Ann Eglash is a clinical professor with the University of Wisconsin School of Medicine and Public Health in the Department of Family Medicine. In addition to practicing family medicine, she has been a board-certified lactation consultant since 1994. Dr. Eglash is a co-founder of the Academy of Breastfeeding Medicine, the medical director and co-founder of the Mother's Milk Bank of the Western Great Lakes, and the medical director of the University of Wisconsin Breastfeeding Medicine Clinic. She has published many peer-reviewed articles on breastfeeding medicine, has been the lead author on several Academy of Breastfeeding Medicine protocols, and is an associate editor for Breastfeeding Medicine Journal. She co-hosts and produces the Breastfeeding Medicine podcast, available for free on iTunes. Lastly, Dr. Eglash is founder and president of the Institute for the Advancement of Breastfeeding and Lactation Education, a nonprofit organization dedicated to the creation of breastfeeding knowledgeable medical systems and communities. Without further ado, I'll be turning things over to Dr. Eglash. Thank you.
Thanks, Jordan, and thanks so much for having me. Hello out there. I probably would recognize many of you who are joining today. So thanks for joining on this conversation. And again, I encourage you to ask questions. I think, as Jordan mentioned, we'll take questions at the end. So our objectives today, first we'll talk about the risks of contraception to infants, and then we're going to talk about the safest forms of contraception during lactation. We'll talk about the lactation amenorrhea method, and then sort of compare the World Health Organization and the Center for Disease Control recommendations for immediate postpartum contraception. That's probably where most controversy comes in when we're talking about hospital systems particularly. We'll talk about the existence of bias and health inequity regarding contraception and race, ethnicity, and then just some key points in optimizing that shared decision-making that needs to happen between healthcare providers and patients when we're talking about birth control. So just for your own like sort of guess and stimulate some thought, what percent of pregnancies in the United States do you think are unintended? You can kind of just throw it in the chat. What do you think? We won't do a poll. Very good. Yeah, most of you know this already. It's like 46%. That's great. Not great for people who have unintended pregnancies, but you guys are knowledgeable. And so this is why birth control is so important. Having that counseling is so important for families. And yes, it may be that they're knowledgeable and it's a matter of like just behavior, but knowledge is really important as well, right? So when we look at this, the most effective forms of birth control, there are the reversible ones and the permanent ones. So the reversible ones are going to be the implant, which in the United States we tend to call Nexplanon or etonogestrel. And then the IUD, which either can be copper, which is a little less effective than the IUD that has the progesterone in it. And then permanently, the most effective, that's the most effective way for birth control is sterilization with the tubal ligation or a male vasectomy. In the next category of effectiveness, where we're looking at like 6 to 12 pregnancies per 100 women in a year, there's the injectable, which is typically Depo-Provera, and the birth control pill. About 9% of women will become pregnant each year on the birth control pill. The birth control patch, which is a combination of progesterone and estrogen. The vaginal ring, which many people know as a NuvaRing, although there are some progesterone vaginal rings out there that are used in other countries. And then the diaphragm is about 12% of women using the diaphragm will become pregnant each year. And then if we look at the least effective methods, where we're seeing somewhere between 18 or more women per year, per 100 per year becoming pregnant, it would be the condom, either the female or the male condom, withdrawal method, the vaginal sponge, spermicide, and then fertility awareness methods, which are also called ovulation methods. So first, I just want to talk a little bit about hormones, and please, you can see this is a hand-drawn kind of wiggly chart just to explain what's happening during pregnancy and postpartum to understand why hormonal methods may have an impact on lactation. So during pregnancy, women have pretty high levels of progesterone and estrogen, and prolactin actually is surging during pregnancy. So prolactin levels actually reach their peak towards the end of pregnancy. And then prolactin is that hormone that's telling the breast to turn, it actually is the hormone that tells the breast to turn on and start that assembly line of milk production. So it's really it has the master key, and it has to be present on a regular basis in order to keep up that manufacturing of milk. Now, as time goes on and as women tend towards 4 to 6 months, prolactin still plays a role, not as important of a role as frequent emptying, but it still always has some responsibility in making sure that the machinery, the milk making machinery, is continuing to happen. And I like to think about milk making as an assembly line process. So what's happening during pregnancy is that the prolactin level is really high, right? And so then why is milk not being made during pregnancy if that's the case? Well, the reason for that is because progesterone and estrogen are so high. And so they block prolactin's ability to turn on that whole apparatus of the whole process of milk production. So these hormones need to go away, and that's the delivery of the placenta, because these hormones are coming from the placenta. So delivery of that placenta allows prolactin to actually knock on the door and open the door and get that process of milk making to happen. So again, when the progesterone when the placenta drops, and progesterone drops with it and estrogen, then we start to see an increase in colostrum, and then gradually over the next 2 to 5 days, we have this gradual increase in milk, and women will say, oh, I feel like my milk is coming in. And that's why it takes a number of days for that to happen. And there are some other factors too, like some women have a longer delay in that milk coming in because of other things such as having diabetes or insulin resistance. So what we're concerned about is that giving progesterone early may send a message to the breast that progesterone is still there, that the placenta is still there, that the baby isn't delivered yet, and so don't make the milk yet. So we don't want to confuse the body. We want to just get rid of that progesterone, and theoretically that has been the big concern about using progesterone early postpartum. Now, estrogen is a much stronger inhibitor of prolactin at that cellular site. So this is now alveolus, and this is where milk is made, and there's cells that line the inside of the alveolus, and so the milk is spewed, the fat globules are spewed into the center of the lumen, and then they go out the door through the duct. So this is just that schematic, but what I'm trying to point to is the prolactin has an effect directly at each of these little cells, and then estrogen blocks prolactin's ability to turn on machinery in every cell. So first let's talk about contraceptive measures. So we're going to get back to that whole issue, but that's the concern hormonally about introduction of hormonal contraception. So let's look at methods that have like least impact. So barrier methods are generally really safe during lactation. Condoms, spermicide, the diaphragm, vaginal sponge, even though there is that concern about having less effectiveness, these are really very safe. The copper IUD is also, that's sort of in that higher effectiveness category, and is not going to really affect lactation because it doesn't have hormones. And then of course, sterilization procedures, a vasectomy, a tubal ligation, that's also going to be safe during lactation. Let's talk a moment about the lactation amenorrhea method. So the women who, we're going to talk about the algorithm to figure out which women are candidates for this method to work. So if a woman does not have her period yet, so we're asking, are you amenorrheic, which means amenorrhea means not having your period. So do you have your period, meaning you shouldn't have your period if this is going to be effective. Are you fully or nearly fully breastfeeding, which means that she's only supplementing with like formula or giving food no more than once or twice a week. Is her baby less than 6 months old? So this method is only going to work if the baby's under 6 months old. If that's the case, if she meets all these criteria, she has a 1 to 2% risk of pregnancy at any time. So there are some behaviors that contribute to the success of the lactation amenorrhea method. And those include being an exclusive breastfeeder. So if mom is really with her child on a regular basis and is always breastfeeding and not giving any supplementation, even that, once or twice a week, it's going to be more effective. If she's feeding frequently, so if you think about my graph of the progesterone always popping up with every suckling and every milk emptying, the more often she's doing that, the less likely it is that the prolactin is going to come down. And when prolactin comes down, that's when the ovaries are like, okay, nursing's over, time to get pregnant again. Let's get ovulation going. And so keeping that prolactin up is really the name of the game. And the way to keep it up is to have those frequent feedings and avoiding long breaks overnight. So long breaks, so the typical recommendation that I make for women to help to optimize lactation and to prevent their periods from coming back tends to be not taking more than a 5-hour break until 3 months, not more than a 6-hour break between 3 and 4 months, and not more than a 7-hour break after 4 months. So the other thing is that we want her to really be breastfeeding as opposed to pumping. So pumping is not as stimulating to that prolactin level. Prolactin depends on direct nipple stimulation. So the nipples have to feel the baby there. And pumping, I mean, there is some nipple stimulation to pumping, but it's not the same as actually having the baby's mouth on the nipple. So studies show that the prolactin doesn't pop up as much. So breastfeeding directly is going to be more effective to keep that prolactin level up. And then actually some women rely on the lactation amenorrhea method after 6 months, and it can be somewhat effective if a woman is breastfeeding before giving, if mom is breastfeeding before giving solids, and that maintains her frequency of feeding. And then to continue breastfeeding at least every 4 hours in the day and no more than a 6-hour break at night. Although I had said 7 hours, this is what one document had indicated. And then for women who are sporadically sexually active, she could consider, if she's largely using this method, not having intercourse very often, she could consider the use of emergency contraception, and we're going to talk a little bit about that later. If she is pumping or adding, supplementation on a pretty regular basis, then really to add a regular method of contraception if she knows that she does not want to become pregnant. The natural family planning method is an option during lactation. So there are multiple protocols on doing this. I'm not a specialist in this area at all, so if you ask me questions, I won't know a lot about the different types of methods. But there is documentation that in the multiple protocols that are available, using different measures other than just the return of menses would be important. So temperature checking, cervical mucus, and other hormonal monitoring. So again, a lot of protocols have the postpartum protocol, although there is evidence that the ovulation method risk of pregnancy is higher in breastfeeding women than it is in non-breastfeeding women. And this is probably because even if a breastfeeding woman is ovulating or has her menses return, she may not be ovulating as regularly because of that higher prolactin level than a woman who's not lactating. So it just may be, so using that menses may not be quite as reliable. So this is just a screen capture of the Center for Disease Control Contraception Medical Eligibility Criteria. So there's actually an app that you can download on your phone, I think it's free, that talks about like the different considerations for different types of birth control based on a woman's health situation. So there are several health situations that are considered in this app, such as a woman with migraines or high blood pressure or seizures and smokers. And so they also have the medical eligibility criteria for lactation. And so we're going to talk about that and then also talk about the World Health Organization recommendations. So this is one portion of this chart from 2015. And you can see that it's broken down into different times. So here, the condition that we're talking about is breastfeeding as opposed to migraine or diabetes or something like that. And so here are the different types of birth control. So the copper IUD, the progesterone IUD, the implant, which is like Nexplanon, the DMPA is Depo, the progesterone only pill, and then the combined hormone contraception, which is like the NuvaRing or the patch or the pill that has both estrogen and progesterone. And so they break it down by time period and whether or not a woman has had a history of a blood clot, which is what VTE is. And so what I want you to pay attention in this chart right now is that what these numbers mean. So one means note that there's no restriction. There's no evidence that there's any harm whatsoever with that method. Two is that the advantages probably outweigh the risks. And so it's a sort of a green light. Three is theoretically the risks usually outweigh the advantages. It could be used, but caution is necessary. And then unacceptable health risk, which you can see the biggest unacceptable health risk is using estrogen less than 21 days postpartum. And that's not just a lactation thing, that's for anyone because of the risk of blood clots. But definitely would crash, I mean, there's very high chance that it would crash lactation as well, but we don't want to do that because of the risk of blood clots. So this is the wheel. So as opposed to that app that the Center for Disease Control has, the World Health Organization also has their medical eligibility criteria for lactation and other things as well. And so if we, this slide is meant to compare the two. So again, the purple is from the World Health Organization, from the wheel, and then I put in the red, which are from the Center for Disease Control. And you can see that there is a difference in their recommendations. And we're going to talk more about this in detail. But you can see that in general, the numbers tend to be higher for most of these things for the World Health Organization. So they tend to be more cautious on many of these methods of birth control as compared to the Center for Disease Control. And this is mainly because of a difference in interpretation of the data. So first, before we kind of launch into that whole area and looking at these different types of hormones and the differences between the Center for Disease Control and the World Health Organization, I just want to mention that the safety of hormonal contraception in infants is generally good. So there are low levels of hormones in breast milk, and it's not generally found to affect the composition of breast milk or the volume of breast milk. Well, no, I shouldn't say that. We're going to talk about volume in a minute. Well, the effect of the hormone, it's not going to affect the hormonal status of the child, and there are just low levels in breast milk. So we're not really seeing any unusual growth or development, breast development, puberty changes, or anything else unusual when infants are breastfeeding and they're exposed to these hormones. So first, let's talk about the progesterone-only pill during lactation. So the Center for Disease Control recommends that it's a level 2 until 4 weeks. So again, a level 2 means that the advantages outweigh the risks, but it doesn't mean there's no risk. It's not a 1. And that level 2 means the risk is really the effect of the progesterone on lactation, that it might have an effect on milk supply. It's a level 1 after 4 weeks. And the World Health Organization agrees that it's a level 2 until 6 weeks. And then they recommend waiting until 6 weeks to know for sure that it's not going to affect lactation. And I would say from my experience, it's pretty unusual for the progesterone-only pill to affect lactation, except we'll talk a little bit about maybe some groups of women who are at slightly higher risk of drop in milk supply when exposed to any hormones. So Depo-Provera, so this was very controversial for a while when it was used much more often. It's not used quite as much, but some women opt to choose Depo postpartum. The company that makes Depo recommends waiting until 6 weeks. The Center for Disease Control feels that it's a level 2, so advantages outweigh risks until 6 weeks, and there's no risk after 6 weeks. The World Health Organization recommends that the risks outweigh the advantages until 6 weeks. And again, that's regarding like lack of lactogenesis 2, the effect of the hormone on prolactin and the effect and drop in supply. But there's no risk after 6 weeks, which is somewhat problematic as well. So there are definitely cases that many of us have seen in lactation where women have received Depo shots after 6 weeks who are lactating and have had a drop in their milk supply. There was a review of contraception from the Academy of Breastfeeding Medicine in 2012. And the concern about these studies is that they're pretty low quality. Many of them don't really have a follow-up. They don't follow up infant weight very well. There's no exact measure of milk volume or how much supplementation is being given. And this is a theme that we're going to talk about. And so what was recommended in 2015 is that there be a consideration of some populations who may be at higher risk for having a negative effect of progesterone on their milk supply. And these would be women who have a history of low supply already, or do have a low supply at that time. So they may have something called insufficient glandular tissue, or they know that they have had a history in the past and are looking at birth control, what they're going to use before they leave the hospital. If they've had a history of breast surgery, particularly a breast reduction, they're expected to have a low supply. Multiple birth, where women are needing much higher volumes of milk, or a preterm birth, where for some women they didn't actually finish breast development yet, and so and they're relying on a pump and have so many other challenges, or when there's compromised health of the mother or the infant. So the Center for Disease Control, they did update their medical eligibility criteria in 2016, and they stated that they actually did state this, that certain women might be at risk for breastfeeding difficulties, such as women with previous breastfeeding difficulties, certain medical conditions, and that might be someone who has insufficient glandular tissue because of insulin resistance. That would be someone to consider at risk, or certain perinatal complications in those who deliver preterm. For these women, as for all women, discussions about contraception for breastfeeding women should include information about risks, benefits, and alternatives. And that's that shared decision-making that we're going to talk more about. So let's talk a little bit about emergency contraception during lactation. The copper IUD is felt to be safe. So that is one option for emergency contraception. It needs to be inserted within 5 days of having intercourse. And then there's one called Ella, which is the ulipristal, and that's a progesterone receptor modulator. It's really not ready for prime time. We don't have a lot of information during breastfeeding, but there is a little evidence that it has low doses of breast milk. So probably the one that's preferred for breastfeeding women is a levonorgestrel, which is progesterone only, and that's preferred over the combined oral contraceptive pill. So you can use the regular birth control pill, but because of the estrogen, there's a good chance it'll drop the supply. So the safest one is probably either the copper IUD or the levonorgestrel. So let's talk about IUDs here for a moment. So the copper. So when we look at the timing of putting in the IUD, if we look at the time period between 10 minutes after delivery and 4 weeks, these are both level 2. And part of the reason that even the copper is level 2 is because of the risk of expulsion. So the risk of expulsion of the IUD is much, much less if it's inserted within 10 minutes after delivery. But after 10 minutes, from 10 minutes on to 4 weeks, there's a higher risk of expulsion. But there's also, for the progesterone IUD, there is evidence of breastfeeding difficulties. So again, that progesterone exposure in the uterus, early postpartum, in the first 4 weeks, there's that theoretical risk of not making enough milk. So the IUD has not been found to be harmful for infant health, growth, or development. And again, discussing the risks, knowing that certain women may be at risk for breastfeeding difficulties. When the IUD is placed after 4 weeks, generally for the Center for Disease Control recognizes these as being very safe postpartum. The only issue is that there is a slight increased risk of perforation among women who are breastfeeding. And then they do say certain women might be at risk for breastfeeding difficulties, but generally those of us in lactation tend to rarely see anything happening with lactation when an IUD with progesterone is inserted after 4 or 6 weeks. I have seen it occasionally though. I mean, it's maybe once a year or less often, but I do think that it exists. And again, there are these women who we don't know yet who may be at risk. So again, it's that shared decision making. I guess one thing I want to mention is that is this expulsion rate. So this is from the ACOG website, that they support immediate postpartum LARC insertion as a best practice, recognizing its role in preventing unintended pregnancy and that short interval pregnancy. So they very much are pro-LARC. And they do address the issue of expulsion rate. And they say, despite the higher expulsion rate of immediate postpartum IUD placement over interval placement, which is waiting until like 4 to 6 weeks, evidence from clinical trials and from cost-benefit analyses strongly suggests the superiority of immediate placement in reducing that risk of unintended pregnancy in those that shorter time period. And that's largely because of many women are at risk for not being able to come back for the postpartum check. And that can be women who live far away, women who move, women who switch insurance or lose insurance, may not have access to postpartum care. So in terms of the expulsion rate for immediate postpartum IUDs, it can be as high as 10 to 27%, whereas the full glass way to look at it is that 73 to 90% of women will retain the device. So anyone who has expulsion really should use another form of birth control and contact their healthcare provider. And the replacement cost can vary, so that can be an issue for some women. I want to talk a little bit more looking at the research regarding these IUDs because of the difference in recommendations between the World Health Organization and the Center for Disease Control. So the first study that came out regarding the placement of the progesterone IUD immediately postpartum versus 6 to 8 weeks postpartum was published in 2011 and was concerning. So this was done in Pittsburgh, and they had 102 women, and they divided them up, they randomized them to either receive the IUD early, right away, immediately postpartum, versus 6 to 8 weeks postpartum. And all the women wanted an IUD, and they all had an intention to breastfeed. And they were told that the IUD would not impact breastfeeding. So if you look at the difference, this was actually pretty impressive. And so they So actually they did, I take that back, they did not all have the intention to breastfeed because it actually ended up being not very highly powered because only 32% breastfed, initiated breastfeeding if they had it placed immediately postpartum, and 27% breastfed when they had it placed delayed, like at 4 to 6 weeks. And so you can see though that the rate of breastfeeding was much lower in those who had it placed immediately postpartum. So if you look at exclusive breastfeeding, it was 12.5% among those who had it done immediately, and 37% when it was placed in later. And the 3-month postpartum any breastfeeding was 21% versus 48% when it was put in later. Only 3% were exclusively breastfeeding, so that was just one person versus 9 women who had it placed later. And then again, 6-month, huge difference in 6-month rate of any breastfeeding from 9.4 compared to 40.7%. So that was a huge issue. And many of us thought, gosh, this may have a huge impact on lactation. But it didn't really measure any other parameters to understand these differences. And then if we look at another study that was done looking at immediate postpartum levonorgestrel IUD placement and breastfeeding outcomes, this was done in New Mexico and Utah. And so it was a larger study. There were 132 that were placed, 132 women who had their IUD placed immediately postpartum versus 127 who had it placed between 4 and 12 weeks. And what they measured was the delay in lactation, like when women felt full and in early postpartum, and whether or not they were breastfeeding at 8 weeks or 6 months. And as you can tell, if you're just asking, are you breastfeeding or not, that's not really telling us like how is that affecting lactation. So if you look at the timing to lactogenesis, there didn't seem to be any difference between those who had IUD put in early versus late. So this is early, this is late, but it basically looks the same. But if you look at any breastfeeding reported from 2 weeks to 6 months, you can see that those who had their IUD put in early, you can see that it really diverts quite a bit, that they had lower rates of breastfeeding at particularly at 8 weeks, 3 months, and 6 months compared to women who had it placed delayed. Now, everyone did drop their breastfeeding rates, which is normal in the United States, or typical, I should say. But they do not see this as being a significant difference. And so what they concluded is that the immediate postpartum insertion was not inferior to later insertion. Again, they didn't report on supplementation volumes and the adequacy of the milk supply for either group. So let's talk about the implants. And again, the implant, the recommendation by the World Health Organization is that it should be a level 2 when placed early, under 6 weeks, and even between 4 and 6 weeks that it's a 2, but then it should be safe after 6 weeks. And then the Center for Disease Control feels that by 4 weeks that it is safe and won't impact breastfeeding. So this was a study that was done in Malawi, and they took 140 women and they asked them if they would like to have the enonorgestrel or the levonorgestrel implant. And we're talking about the implant that goes in the arm, the progesterone stick, as you can see right here. And so the enonorgestrel is known to last for 3 years and the levonorgestrel for 5 years. And what they found is that nearly all the women who were in this study were married, and those who chose the enonorgestrel were more likely to want children, more children than those who wanted the longer one. And more than 90% of these women had vaginal deliveries. So they followed these women every 3 months until 24 months postpartum to understand the differences. So what they found first is that in comparing these two, it didn't really matter, but you can still see there's some decline in exclusive breastfeeding over time. And so the question is, does this implant itself create this problem over time? There really was no documentation on infant growth, and they, again, didn't really identify women who were at risk for insufficient milk supply. And that's, one of the problems with all these studies is that, are we really capturing the women that we are most concerned about? And then there was another study that was done, that was published last year, that was done in Uganda, where they placed the implant within 5 days or at 6 to 8 weeks. And then they followed them for documentation of when their milk came in, so that's lactogenesis 2, and then asked about breastfeeding concerns at 3 months and 6 months and checked infant weights. But the problem was that there was not a big difference. There was not a big difference in the interval weight gain in the two groups, so that didn't seem to make a difference. And there wasn't huge, the follow-up was kind of low. So the infants examined at 6 months, 63% for the immediate insertion and 49% for the delayed insertion. So there's a lot of data that was not collected. But what's interesting here is that if you look at any concerns about breast milk supply in these two groups, immediate or delayed placement, you can see that there's still like a quarter of women, a quarter to a third of women had concerns about their milk supply at that point. So the question is, is that there was no control, so we don't know, how many women do complain of their milk supplies at that point. Anyway, in that particular population. But the authors themselves identified limitations to the study in that there was a low follow-up of infant weight checks. They didn't assess for breastfeeding outcomes who were at risk, among women who are at risk. So they didn't identify the high-risk populations, such as those who had premature infants, and they didn't measure the amount of supplementation. So they just asked about any breastfeeding. They did ask about exclusive breastfeeding, and the exclusive breastfeeding rates were about 3/4 for both. So there wasn't a large difference between them. So that's something to think about, what is happening along with these implants. Nevertheless, the American College of OBGYN has been pretty positive about using immediate postpartum long-acting reversible contraception. And their statement that was published in 2016 is supported by the American College of Nurse Midwives and the Society for Maternal Fetal Medicine, as well as the American Academy of Family Physicians and the Association of Women's Health, and then the OB and neonatal nurses. So what they're saying is that immediate postpartum long-acting reversible contraception, LARC, which could be the IUD or it could be the implant, has the potential to reduce unintended and short interval pregnancy. Now, this does not include Depo, because Depo is not considered really long-acting. It is reversible, but it has to be given every 3 months, so it's not truly long-acting. But they do state that women should be counseled about all forms of postpartum contraception in a context that allows for informed decision-making. So informed postpartum LARC should be offered as an effective option for postpartum contraception. There are a few contraindications, and these should be discussed during the antepartum period and counseling about all options. So we want to make sure that women understand their options and they have plenty of time, particularly during their pregnancy, to be thinking about these options rather than being asked to make a decision immediately postpartum. So in summary of the things that I've discussed so far, number one, recognizing that there is a slightly higher risk of uterine perforation due to the IUD among breastfeeding women. The progesterone IUD, the LNG IUD, if it's placed less than 10 minutes after delivery, there's evidence that it does increase the risk of insufficient lactation, likely due to insufficient drop in progesterone postpartum. We haven't proven that it's not doing that. And then the progesterone contraceptives, norgestrel implant, Depo, the progesterone-only pill, can increase the risk of insufficient lactation. So according to the Center for Disease Control, that's under 30 days. And again, many of these are 2 because of that. And according to the World Health Organization, under 6 weeks postpartum. And then the combination birth control pill that has estrogen and progesterone can increase the risk of insufficient lactation at any time. And I would just emphasize that as a breastfeeding medicine specialist, I use the pill with estrogen. I use estrogen to reduce milk supply no matter where women are postpartum, whether they're 3 months postpartum, 6 months postpartum, 9 months postpartum, 2 years postpartum. Estrogen generally will drop the supply. So it's important to recognize that there is a lot of enthusiasm, as I've shown with the support of the ACOG statement regarding postpartum LARC. And that's because they last a long time, right? So the Nexplanon, the implants can last 3 to 5 years, depending on which one you have and recent research. And then IUD can last anywhere from 3 to 12 years. So it's great for women who are not planning to have another child for a long time. So there is an initiative called the Postpartum Contraceptive Access Initiative, which you can find through the ACOG website. And what they state is that given available evidence, ACOG recommends that women who are considering immediate postpartum hormonal LARC should be counseled about the theoretical risks of reduced duration of breastfeeding, but that the preponderance of the evidence has not shown a negative effect on actual breastfeeding outcomes because the evidence is not great. Systematic review findings show that progesterone-only contraceptives do not appear to adversely affect a person's ability to successfully initiate and continue breastfeeding or an infant's growth and development. And again, it's just whether or not there is a drop in supply. But there are theoretical risks that exogenous progesterone could prevent lactogenesis, but observational studies of progesterone-only contraceptives suggest no effect on successful initiation and continuation. And then kind of giving that plug for the copper IUD, which lacks hormones, and it really avoids any theoretical risk on breastfeeding, and that's considered a medical eligibility criteria, category 1, for women who are breastfeeding. So that's a great option for someone who wants long-term contraception and doesn't want to take any possible hit to their milk production. So ACOG recommends a shared medical decision-making, which I already, I think, has stated a couple of times, that OB providers, OB care providers should discuss the limitations and concerns associated with the use of hormonal LARC within the context of each woman's desire to breastfeed and her risk of unplanned pregnancy so that she can make her decision herself. So what I'm saying, and what I think all of us in lactation are saying, is that it's not that these are bad, because every woman has to make a decision. If she's very, very worried about becoming pregnant again and would rather take the risk to her milk supply, and it's theoretical because she may do fine, and take that risk in order to not get pregnant, that is definitely important for her to make that decision. So Jordan, what time do you want me to end? I'm pretty close to be done.
It doesn't look like we have any questions coming in yet. So if you want to go till 1:20, that should be fine.
Okay. It's important that there be equitable, appropriate means of implementing early LARC. So this was a case that was documented in one article published last year. The following situation occurred at our institution. A 15-year-old Latina gravida 2 para 0111 had a spontaneous vaginal delivery of an extremely premature infant. On her day of discharge from the hospital, a lactation consultant entered a room just as an OBGYN resident was eliciting her consent for a contraceptive implant placement. The lactation consultant asked the medical student who was in the room with the resident whether breastfeeding had been discussed. Once prompted, the resident advised the patient of a possibility that the implant could impact her milk supply, and the patient decided not to have the implant. So the resident texted his attending saying, "I just talked to one of the lactation consultants who advises women that immediate postpartum contraception may decrease milk supply. I'm not aware of literature to support this. This was in a 15-year-old on her second pregnancy who just delivered a 25-weeker. Obviously, I'm all for breastfeeding, but I feel like presenting her something that is based on the LC's experience is not really neutral and fair, especially in such a high-risk teen, and when the literature on postpartum and immediate contraception is so compelling." So what we have is some discord between the interest of the providers, which is the interest in spacing to reduce the risk of another preemie, reduce the unintended pregnancy, emphasize a lack of evidence for adverse effect on lactation, versus on the lactation side, the interest in lactation success, health of the premature infant, making sure the infant is receiving adequate mother's own milk, and emphasize a lack of evidence for safety of contraception during lactation. So the problem, again, with most studies is that they show little impact on breastfeeding, but again, the findings are not applicable to complex heterogeneous postpartum populations. They're usually not diverse populations. And then most studies are enrolling healthy women with healthy term infants. So we're not looking at populations of preterms, small for gestational age, women who are exclusively pumping, multiples, those who have health problems that we know have an impact on supply, such as diabetes, high body mass index, insulin resistance, breast reduction, et cetera. So if we think about just some of the evidence on social justice, we know from research, and I'm not going to go through all the different studies, but we know that there's evidence that there is a lack of equity regarding education on contraception. This has been documented in the military even. For some populations, the state Medicare approval for LARC has been perceived as an infringement of reproductive rights without adequate implementation. So if it's not implemented appropriately to make sure that women are receiving their prenatal counseling, and then they're making sure that someone is listening to their decision prenatally, and that decision is followed through postpartum, and then they have their follow-up, it can be seen as really not fair and equitable. Physician enthusiasm for LARC has been shown to lead to implicit coercion. Healthcare providers' counseling on contraception varies based on race and ethnicity. That's been shown. And then there are barriers to LARC removal, particularly for women who have it placed and then they lose their insurance and don't have the ability to have it removed, or it falls out and they can't get it replaced. So what are some key disadvantages and key considerations for intrapartum LARC planning? So first, we want to make sure that these devices are placed by someone who's trained. People may lose their insurance, which I mentioned, which limits access to removal services. There are possible contraindications, which we want to make sure are being addressed. There's an increased risk of expulsion, and some women don't recognize it. They're not always checking their strings to know for sure. Possibility of non-visualizing the strings and then difficulty to have it removed. Some women have had to go to the OR to have it removed or need an ultrasound to find it. And then healthcare provider bias contributing to coercion. So this is just to show you that some states, South Carolina was the first state to put together a postpartum LARC toolkit. So they were the first state to have Medicaid pay for immediate postpartum LARC. And they had a really nice toolkit that helped making sure that all women had access to this education prenatally, and that you had professionals putting it properly, et cetera, et cetera. And I think that these toolkits are really important when there are decisions such as Medicaid actually having a policy on approving use of LARC. Texas has a toolkit, West Virginia has a toolkit, and this link will send you to the list of toolkits by state, actually. Indiana has a good one as well. And so again, shared decision-making, it's important for healthcare providers to not pre-decide for individuals, that this education needs to happen during pregnancy. There needs to be education on the efficacy, the cost affordability of it, the possible impact on lactation, other side effects and complications, and then plans for removal or how their insurance would deal with removal or when it gets removed. So this is just we're at the end of this lecture, but this is this was taken from one of the articles that I found about this issue. Actually, it was taken from one of the toolkits. I take that back. I think the South Carolina toolkit on a way of introducing this topic and having this conversation with a mother regarding how to help her weigh her decision on the use of birth control, evaluating her her intentions on breastfeeding, her goals for breastfeeding. So how long does she want to breastfeed? What would make it harder for her to breastfeed? Her birth spacing, contraception values, her sexuality, and then the whole issue about breastfeeding and hormonal contraception, sort of that gray area that we don't know some details about that, and some questions like what would happen if you didn't make enough milk and you were given this birth control, how would you feel about that? Would that be terrible? So understanding, helping her walk through this to figure out how to make the best decision. Here are some resources, postpartum contraception, bedsider.org, the American College of OBGYN, that the PCA initiative is a great resource, Center for Disease Control and Reproductive Access.org. So in conclusion, the effect of hormonal contraception on lactation is really not very clear, particularly for high-risk populations. Current research has not used optimal measures for lactation success, so we have a great deal of work to do to improve our research to understand who would be at risk. The current CDC and World Health Organization recommendations on medical eligibility criteria for contraception for breastfeeding women do differ, but I think it's just imperative that healthcare providers understand that a 2 is not a 1, and that all of these progesterone contraceptive methods under 6 weeks are a 2. And so there is that theoretical risk, and every woman needs to understand that. Both the CDC and World Health Organization acknowledge that it may impact lactation, and that patients need adequate information for fair shared decision making that actually happens prenatally. So any questions?
It looks like we do have a couple questions that have come through. First one, why is the risk of IUD perforation higher among breastfeeding women? And is it just a slight risk or higher?
It's thought to be slight enough that it's not a reason to avoid putting in the IUD because it's such a great method of birth control, but it's probably higher because when women are breastfeeding, they have oxytocin release, and oxytocin actually has stimulating effects on the uterus. So it actually causes a little bit of a uterine like tightening because of the oxytocin receptors in the uterus.
Great. Thank you. And if anyone else has any other questions at this time, please feel free to put those in the chat to all panelists as well. We do have a couple more that came through. This is again related to IUDs. How come the IUD is less likely to expel if it is inserted within 10 minutes after birth?
Yeah, I'm not sure. Yeah, I really don't know that. I'm not sure actually.
Okay. And what hesitations do you tend to find from pregnant or new moms to these guidelines or recommendations, and how do you advise addressing those?
So can you ask that again? I'm not quite sure about that question.
Sure. I'll say the first part and then can have you answer the second one later. What hesitations do you tend to find from pregnant or new moms to these guidelines or recommendations?
Mm-hmm. Well, I think that women are so my point of view is that I'm breastfeeding medicine. So I'm a family doctor too, but almost all the questions that I receive about birth control tends to revolve around lactation. And so there's a great deal of concern about lactation, about using birth control, and how that birth control is going to affect their milk production. I would say that's my world. There may be a different world among other providers where their patients are most concerned about the most effective form of birth control, and they're not as concerned about breastfeeding. But so I would say that effectiveness likely, but in my population, it's mainly the effect on lactation. Okay.
And then the second part of that question was just how do you advise addressing those concerns?
Yeah, so I think for me, I would say that I'm sort of more aligned with the World Health Organization guidelines because I think they're just a little bit safer. They're a little bit more cautious. But I, again, try to, weigh people's, what their priorities are basically. But I would say that if women are asking me specifically about how much to worry about their birth control regarding breastfeeding, I usually say that if women are doing really well, particularly if they have a pretty abundant production, so they're maybe nursing 1 breast per feed, they could easily store, an extra 6 or 8 ounces of milk a day, et cetera. They're nursing well. I usually tell them, the progesterone is not going to be a problem. Now estrogen, yes, I do advise not to ever use estrogen during lactation unless it's not a problem for them to drop the milk supply. So if a woman is saying to me, I'm ready to wean, I'm 12 months postpartum or whenever it is, what are some good ways to wean? And I have kind of a high supply and worried about having plugs or mastitis. And I say, aha, if you're going to use a birth control with estrogen, if that was your plan, this is a great time to switch the birth control pill with estrogen. And that really does help women with their ability to wean when they're worried about having a high supply. So then women who are struggling with a low supply, who have insufficient glandular tissue, or are struggling because they are pump dependent or something like that, I usually will encourage them to avoid even the progesterone-only pill. Now, the IUD, it's really uncommon to see a drop in milk supply with the progesterone IUD. So if that makes sense to them, because that seems to be a very secure, preferred form of birth control, then I would say, wait until 6 weeks. But then that is less likely to affect milk supply than even the progesterone-only pill.
Thank you. It looks like we did have another one come in while you were talking. Is there any research currently that is examining the effects of breastfeeding in LARCs?
So I did present, some of the research already about long-acting reversible contraception and the effect on breastfeeding. And again, the studies are not great. I don't know what trials are out there right now. And hopefully what I would encourage anyone who's researching this is to make sure that you have a lactation consultant, someone who understands protocols, someone who understands what needs to be measured in terms of breastfeeding success. And some of these actually were pretty well done, like that study with the IUD, the progesterone IUD in 2011, that did show a significant difference in the rates of exclusive breastfeeding. But again, these were very small numbers of women, so we need large numbers as well. And they need to be randomized controlled trials, because if we just do surveys will include women who did well and women who didn't, but then we really don't know, we're going to get much better data if this can be a randomized controlled trial.
Thank you. Follow-up question. We have a big push from our OB providers for depot and implants while in the hospital, and that ACOG states that it does not affect lactation. How can we ensure shared decision-making?
So this is really what I have been emphasizing in this lecture, is that ACOG does not say that it does not affect lactation. The PCA initiative is a great place to start, that says specifically that shared decision-making is important. Even in their 2016 statement, ACOG states that there needs to be shared decision-making, that there is this possible decrease in milk supply. So it can affect lactation. So what healthcare providers, what needs to be emphasized is that a 2 is not a 1. If they look at the medical eligibility criteria from the Center for Disease Control, it says a big fat 2, not a 1. The 2 means that there is a possible risk. And even though it's a green light 2, meaning like, oh, the benefits probably outweigh the risk, not a problem, you still have to share that with women, right? That's only fair. And so I think that there's enough information out there between the Center for Disease Control and ACOG itself that every OB provider should be able to read that and understand that if they don't address that, they're embedded in that coercion, and because they're not sharing adequate information. So even like, for example, if I give someone, a medication for their osteoporosis, generally it's going to improve their bone strength. But there's that really small, tiny percent of women who may develop atrial fibrillation, who may develop a pathologic fracture just by taking these. I need to tell them that, right? It's only right. It's only fair that we always give, even if it's a very slight increased risk, we have to share that. And so that is, I feel is the miscommunication that's happening, is that they need to read the fine details from ACOG and the Center for Disease Control.
Thank you, Dr. Eglash. It looks like we're just about at time. Are there any last minute final questions anyone wants to put in the chat? And if anyone is thinking about any, I will just share too that we will be sending the evaluation and nursing contact hour form to you via email by the end of today. And again, we just greatly appreciate your feedback. So if you could fill out the evaluation, that would be wonderful. And I will wait here for a second to see if any other questions come through.
Well, thanks everyone for having me. I hope this was educational, and I would imagine, Jordan, that maybe people can contact HCET and you can pass on any questions that people may have for me.
Absolutely, yeah. If you have any additional questions for Dr. Eglash, you can pass those to me. My email is in the slides that were sent to you before this webinar. But yes, thank you, Dr. Eglash, and thank you all for attending. I hope you all enjoyed this, and I hope you have a great rest of your day.
Thank you. Bye.